So after the clinical presentation and workup and ultrasound evaluation of the thyroid nodule, we move on to the sonographic risk stratification of thyroid nodules. The sonographic characteristics in thyroid nodules that appear to confer the highest risk of malignancy, specifically papillary thyroid carcinoma, include the presence of microcalcifications, hypoechogenicity, irregular margins, and taller than wider nodule shape. Size is also thought to be a predictor and is clinically relevant, although whether size is an independent predictor is controversial. Intranodular vascularity has historically been thought to also be predictive of malignancy, but is likely more correlated with follicular thyroid carcinoma than papillary thyroid carcinoma. Although each individual ultrasound characteristic is relatively unreliable in isolation for predicting malignancy, the combination provides improved specificity. On the opposite end of the spectrum, features such as spongiform pattern or a purely cystic appearance dramatically decrease the risk of malignancy. Because the sonographic interpretation for malignancy is based on synthesizing a constellation of features, large-scale efforts have been made to create graduated risk stratification system with higher sonographic risk nodules recommended to undergo FNA biopsy at a small size threshold. In the 2015 guidelines, the ATA proposed a 5-grade sonographic classification system, which is graphically summarized in this figure. We can see the ATA has divided into benign, very low suspicion, intermediate, and high suspicion. The benign consists of the cyst, which has less than 1% risk of malignancy, whereas the very low suspicion includes spongiform and partially cystic no suspicious features in less than 3% chances of malignancy. In low suspicion, which is 5 to 10%, it includes hyperechoic solid regular margins, isoechoic solid regular margins, and partially cystic with eccentric solid areas, which is also shown in this picture. And the intermediate suspicion with 10 to 20% of malignancy has hypoechoic solid regular margins and hypoechoic solid regular margins as well in this picture. The high suspicion group, which has the maximum chances of malignancy ranging from 70 to 90%, includes microcalcifications. We can see the hypoechoic irregular margins, taller than wider, extrathyroidal extension we can see here, and interrupted rim calcification with soft tissue extension, and irregular margins with suspicious left lateral lymph nodes. So only those nodules in the higher risk categories called high, intermediate, and low suspicion have associated definite recommendations regarding the FNA biopsy, whereas the two lower risk categories called very low suspicion and benign can usually be safely observed. This table summarizes the sonographic categories, their estimated risk of malignancy, and size-based recommendations for biopsy. So despite the prominence of the ATA's guidelines for clinical practice, other organizations and societies also have proposed sonographic risk stratification system for thyroid nodules. Probably the most commonly used alternative is the Thyroid Imaging Reporting and Data System, which is commonly called as TIRADS, which was originally described in 2005 but formalized by the American College of Radiology in 2015. TIRADS stratifies nodule characteristics into 5 risk levels from TR1 to TR5, TR1 being benign and TR5 being highly suspicious nodules. However, the categorization method differs in that it converts feature patterns into a discrete number of points along 5 feature dimensions: nodule composition, echogenicity, shape, margin, and echogenic foci. And the total accumulated points determines the ultimate TIRADS levels. The TIRADS levels in turn determines size-based recommendations for biopsy or surveillance. The size thresholds also vary somewhat from those of the ATA. This picture summarizes the whole concept of the TIRADS. The parameters used are composition, echogenicity, shape, margin, and echogenic foci, and there are points given to each of the parameters, where composition consists of cystic or almost completely cystic, which has 0 points, spongiform has 0 points, mixed cystic and solid has 1 point, solid or almost completely solid has 2 points, and similarly echogenicity has anechoic, hyperechoic or isoechoic, hypoechoic or very hypoechoic with 0, 1, 2, and 3 points. The shape wider and taller has 0 points, taller than wide has 3 points. And regarding the margin, the smooth, ill-defined, lobulated, or irregular extrathyroidal extension has 0, 0, 2, and 3 points respectively. Regarding the echogenic foci, non or large comet tail artifacts has 0 points, macro calcifications has 1 point, peripheral rim calcifications has 2 points, and punctate echogenic foci has 3 points. Based on the findings, we give points to each categories and we add points from all categories to determine the TIRADS level. 0 points is categorized as TR1, which is benign and requires no FNA. And if the point is 2, it is TR2 and it is not suspicious, requires no FNA. Whereas 3 points is categorized as TR3, which is mildly suspicious of malignancy. And if the size of the nodule is more than 2.5 centimeter, then FNA is done. And if it is 1.5 centimeter or more, then follow-up is advised. The point from 4 to 6 is categorized as TR4 and it is moderately suspicious, so FNA is done even if the size of nodule is more than or equals to 1.5 centimeter and the patient is kept on follow-up if the size of nodule is 1 centimeter or more. Regarding total points being 7 or more, it is highly suspicious and categorized as TR5. FNA is done if the size of nodule is 1 centimeter or more and 0.5 centimeter or more is kept on follow-up. The comparative studies to date would suggest that ATA and TIRAD systems perform with high sensitivity and negative predictive value and represent a significant improvement in standardization and completeness in ultrasound reporting. But neither system recommends routine FNA biopsy of nodules less than 1 centimeter. This strategy accepts the trade-off of not diagnosing all thyroid cancers smaller than 1 centimeter against the current reality of many countries experiencing dramatic increases in overdiagnosis of clinically insignificant papillary thyroid microcarcinomas. However, other factors such as the location of the nodule in the thyroid, presence of lymphadenopathy, genetic or environmental risk factors, patient age, and patient preference may take precedence in the influencing whether a sub-centimeter thyroid nodule is biopsied. Ultrasound elastography is a technique that measures the stiffness of a thyroid nodule and that was originally developed with the promise of incrementally improving ultrasound's non-invasive risk assessment of malignancy. Initial results were promising, although follow-up results have been mixed on validation studies. Elastography is a highly specialized technique with unique equipment and it is most effective for only a small subset of nodules. Currently, elastography is not recommended for routine use in the evaluation of thyroid nodules, but it may be useful for selected cases in specialized centers. The most important is the FNA cytology. FNA biopsy is the most accurate and cost-effective invasive procedures in the workup of thyroid nodules. For all thyroid nodules, FNA has a mean sensitivity of over 80% and mean specificity of over 90%. Although FNA can technically be performed without ultrasound guidance for palpable nodules, the accuracy overall with ultrasound assistance is superior. FNA is performed with a small gauze needle, typically 23 to 27 gauge, and it may be performed with capillary or suction techniques. Ideally, the adequacy of the specimen can be confirmed at the time of the procedure with on-site cytopathological evaluation. The excellent discriminatory ability and extremely low complication rate of FNA have rendered biopsy methods with large bore needles such as core needle biopsy obsolete. The indications for FNA biopsy are described in greater detail above and are largely dependent upon the risk profile of the thyroid nodule on ultrasound. For example, FNA would be recommended for higher risk pattern nodules classified as ATA high suspicion or TIRADS TR5. In other words, solid hypoechoic nodules with microcalcifications that are at least 1 centimeter should be considered for biopsy, while very low risk nodules that are spongiform have higher size cutoffs for biopsy or can be observed. Risk factors other than sonographic profile can reduce the threshold for performing FNA biopsy, including positive family history of thyroid cancer, history of significant radiation exposure, and PET positivity. FNA should only be performed if the results would influence the patient's management. For instance, small to moderate size thyroid nodules in the extreme elderly or those with prohibitive surgical risk or in patients without other concerning features who are already proceeding with thyroidectomy do not require FNA. Historically, cytological findings on FNA were broadly categorized into 3 categories: benign, malignant, and indeterminate. Although this system was generally helpful for the majority of thyroid nodules with highly predictive benign and malignant features, its drawback included significant variability in pathology evaluation and reporting and inability to more finely discriminate features within the broadly termed indeterminate category. To address these limitations, the National Cancer Institute convened a State of the Science Conference in 2007 to develop a consensus for cytological terminology known as the Bethesda System for Reporting Thyroid Cytopathology. An updated second version was published in 2017 and is described here. This system formalized 6 diagnostic categories of FNA cytology with an estimation of cancer risk associated with each category based on literature review and expert opinion. These categories in increasing numerical order are non-diagnostic or unsatisfactory, benign, TPA of undetermined significance or follicular lesion of undeterminate significance, follicular neoplasm or suspicious for follicular neoplasm, which also encompasses Huttel cell neoplasm, suspicious for malignancy, and malignant, which is shown in this picture. This table provides a breakdown of these categories and their associated malignancy risk in addition to the possible changes in malignancy risk risk if the new histopathology diagnosis of non-invasive follicular thyroid neoplasm with papillary-like nuclear features were no longer to be included as a malignancy. The broad institution of the Bethesda classification system across virtually all major centers has led to significant improvements in standardization of care, communication of cancer risk with other providers and patients, and research effort. Validation studies in large number of patients have shown overall good concordance in the FNS reporting patterns and malignancy rates. However, there is significant variability in the risk of malignancy in each category, particularly in the ATP of undetermined significance or follicular lesion of undetermined significance category. This has led to the recommendation for each individual institution to define its own patient population's malignancy risks for each of the Bethesda categories by correlating cytology to surgical histopathology from surgical specimens. The next is the molecular testing of FNA specimens. Although no FNA cytology can completely rule out or rule in malignancy in thyroid nodule, the cytologic diagnosis of benign, that is Bethesda category 2, and malignant Bethesda 6 are highly accurate with an error rate of less than 3%. On the other hand, the remaining indeterminate categories, particularly ATP of undeterminate significance of follicular lesion of undeterminate significance and follicular neoplasm, that is Bethesda 3 and 4 respectively, are associated with a cancer risk anywhere from 6 to 40%, with Bethesda 3 nodules falling in the 6 to 30% range and the Bethesda 4 nodules in the 10 to 40% range. Bethesda 5 lesions suspicious for malignancy are also technically indeterminate, but since these are associated with a 50 to 75% risk of malignancy, they are typically managed similar to malignant, that is Bethesda 6 cytology. Traditionally, the malignancy risk associated with the Bethesda 3 or 4 cytology in a thyroid nodule led to the recommendation of diagnostic thyroid lobectomy, but since the majority of these nodules are still ultimately benign on final pathology, efforts have been made in molecular genetics to improve prediction capability and reduce the number of unnecessary thyroidectomies. Advancements in molecular genetics have enabled the creation of relatively affordable high-throughput DNA or RNA-based assays for creating molecular profiles or signatures of cytology samples that would provide more accurate assessment of malignancy risk in thyroid nodules. There are multiple commercial providers for these tests, but the two most prominent tests are Afirma and Thyroid. The Afirma product was the first molecular test commercially available in this space. Its first generation assay, the gene expression classifier, employed proprietary machine learning algorithms on a 167 gene mRNA microarray to separate nodules' gene expression signatures into benign and suspicious categories. The gene expression classifier test's accuracy was first evaluated in 2012 in a study of surgically excised thyroid nodule specimens, and it was found to demonstrate excellent sensitivity and negative predictive value of 90%, around 95% respectively, but with relatively poor specificity and positive predictive value of around 50% and 38% respectively for Bethesda 3 and 4 nodules. Subsequent studies have largely validated the original study's findings, but many of them have been limited by the lack of a true negative reference standard. To address its limitations as a rule-in test due to its poor specificity and PPV, the newest Afirma product, the genomic sequence classifier, improved the core machine learning algorithm for its larger gene expression area of 10,196 genes and also included 7 other upstream components, evaluating for a number of genetic mutations highly specific for malignancy. The performance of the GSC was recently evaluated in a multi-institutional blinded validation study in 191 cytology samples from 183 patients. For Bethesda 3 and 4 lesions, the GSC demonstrated incremental improved performance compared to the gene expression classifier with sensitivity, specificity, negative and positive predictive value of 91%, 68, 96 and 47% respectively, based on a 24% cancer prevalence. Hürthle cell neoplasm remained an area of weakness in the GSC. It accurately predicted Hürthle cell adenoma and carcinoma in only 10 by 17 and 1 by 9 specimens respectively. The Thyroid product approaches molecular classification differently from Afirma in that it employs next-generation DNA sequencing technology to detect the presence or absence of a discrete list of known gene mutations and gene fusions associated with thyroid cancer. This technology is based on work described by Nikiforov and colleagues at the University of Pittsburgh, and the second version of the product, evaluating 13 mutations and 42 fusions, demonstrated promising results in their single institution studies with sensitivities and specificities in the low 90% range, positive predictive value in the high 60 to 80% range, and negative predictive value over the 95%. These initial data originally generated excitement that perhaps the Thyroid V2 would offer the ideal accuracy characteristics because the positive predictive value appeared to approximate that of Bethesda 4 cytology while maintaining excellent negative predictive value. However, subsequent validation studies showed less impressive results. The newest generation Thyroid product improves the number of genes in its mutational panel and incorporates other genetic information such as changes in gene copy number as well as some gene expression data. Stewart and colleagues conducted a prospective blinded multicenter study of the Thyroid V3 in 286 cytologically indeterminate FNA samples with known surgical pathology results. In Bethesda 3 and 4 nodules, the test has specificity and sensitivity of 94 and 82% respectively, and negative predictive value and positive predictive value of 97 and 66% respectively, based on a cancer or NIFTP prevalence of 28%. Importantly, the test correctly predicted Hürthle cell adenoma and carcinoma in 62 and 100% of cases respectively. The early data from both the Afirma GSC and Thyroid V3 suggest promising improvements over previous generation products, and subsequent management guidelines for thyroid nodules will likely incorporate molecular testing to a greater degree. Ultimately, the decision whether or not to use molecular testing needs to be placed in the context of other variables that go into clinical decision making. First, whether to proceed with thyroidectomy may rest on factors other than the results of an FNA biopsy, let alone molecular testing. Second, the price of these assays is not insignificant, and their institutional setting specific incremental value and cost effectiveness must be taken into account. Third, patients should be counseled about the inherent uncertainties in the therapeutic and long-term clinical implications of pursuing molecular testing. So to conclude this topic of thyroid nodule, let's discuss this flowchart. If there is a presence of thyroid nodule, then we first move into history and physical examination and do a serum TSH. If the serum TSH is low, then we move on to the radioisotope scan. If it shows hot nodule, then the iodine 131 or surgery is performed. If it is a cold nodule, then ultrasound is performed. And if the TSH is normal as elevated, we directly go into ultrasound. In ultrasound, we can see if there is a high or intermediate suspicion, low suspicion, very low suspicion, benign or no nodules. This is according to the American Thyroid Association guidelines. In case of high or intermediate suspicion, FNA is done if the nodule is 1 cm or more. In low suspicion, FNA is done in 1.5 cm or more. Very low suspicion, 2 cm or more. And if it is benign or no nodule is seen in ultrasound, FNA is not done. In cytology, you can see that according to the Bethesda classification, if it is non-diagnostic, FNA is repeated. If it is benign, the patient is kept on follow-up. If there is atypia of undetermined significance or follicular lesion of undetermined significance or follicular neoplasm or suspicious for follicular neoplasm, we repeat the FNA with molecular testing or surgery. If there is suspicion for malignancy or the malignant is confirmed, then we directly move on to surgery. So we can see the FNA is repeated in case of AUS or FLUS and FN, and if it is non-diagnostic.